Okay, well, I want to first begin by congratulating Craig Barrett. What a tremendous voice for technology and common sense in behalf of really changing the world of healthcare. I think we're lucky to have someone of that stature taking such a deep interest in this subject. I think it's going to be a great catalyst for change. Secondly, I'd like to congratulate the folks here at Mayo Clinic, David, who I just got to know about a year or so ago, and Nick, for pulling together a tremendous event here. I think it's probably going to be the first of many. But the idea of getting together such a eclectic, diverse group of folks to talk about these issues, I think, is really the beginning of a solution, and I think it's the right way to go. Third, I'd like to just give a disclaimer. Really, the heart of the Media Lab, which is a famous place, is the students. And so my talk today is really an introduction to one of the students of the Media Lab, Dr. John Moore, who will be showing you some of the thoughts and imagination that he has in this area. I guess the role of the Media Lab here is to harness the creativity of the kinds of people who created the Twitters of the world and the rock band and guitar of the world that came out of the Media Lab and all the great things that we know today, and then push that over to this all-important problem of healthcare, and that's one of the things we're trying to do. But before I begin, let me just put this water aside. I'd like to tell a story that reminds us of the fact that this is all about people, and it's all about the patient. And being here at the Mayo Clinic, I think, really drives that home. But I had a story something that actually occurred to me yesterday that really reminded me of we've got to keep that simple fact in mind. And it happened on the way to my flight here to Rochester. I flew from Boston and transferred to Minneapolis. And when I arrived at the gate, the fellow there who was managing the tickets and providing boarding passes, I didn't have a boarding pass, greeted me by saying, "We're overbooked by 5 or 6 people. And I'm sorry, but I don't think you'll probably get on this flight." And I immediately went into my mode of, well, who the hell do you think you are? How could this airline do that? You've been there before. I'm going to call this person and that, or you're going to have to do this or that. You know, you get nuts. And, I'm thinking, well, I got to get to the Mayo Clinic because they have a cocktail party that I don't want to miss, And so I kind of, did the usual thing. I was with John Moore, my student, and we were trying to get on that flight desperately. We knew there were only a few slots. And so, sure enough, after haranguing the fellow enough and just hanging around and looking at him enough, he called my name. And he said, "You're on the flight. Here's your boarding pass." I think he was happy to see me go, And he gave a boarding pass to John as well. And so I grabbed the boarding pass, ran onto the plane, had my baggage with me. And the fellow on the plane said, "You can't bring the baggage on. You have to check that. So you have to go back to the front and get your claim checked." So I ran back to the front, and sure enough, standing there at the gate attendant was there, but 2 people, one a young woman, and the other an older gentleman. And the young woman was appealing to the fellow at the gate, saying, "This older gentleman here wants to go to the Mayo Clinic. He's got some important therapy that he's getting, and he needs to get there in time. Don't you think that you can possibly get him on this flight?" The guy looked clueless, and the young woman said, "You know something? I'm going to give up my ticket. I'm going to send this gentleman on the way." And as I'm listening to this conversation, I heard her say, or we talked a little bit, and I was just about to run back, and she said, "I'm going to this innovation summit at the Mayo Clinic." We talked very briefly because I had to run onto the plane. And she asked the fellow, "Are my bags going to be taken off the plane so I can get them?" He said, "No, they're going to go along," which is strange. You're never supposed to ship bags along with the plane anymore. And so she looked concerned. I just happened to mention to her, I said, "Hey, I'm going to the Mayo Clinic. I'll take your claim checks, and I'll take them, and I'll take your baggage to the airport." When I got on the plane, I felt like such a cat. To think, you're just concerned about your day-to-day business and getting where you want to go. And here's a woman. Actually, her name is Shannon Fuchik. Shannon, are you here? If you can raise your hand. It made me think, not only did she give up her seat, and I think had us all in perspective, but she gave her claim checks to a total stranger. So not only was she kicked off the flight, but she never knew if she'd see her baggage again. And it kind of reminds us about our priorities in life and the fact that It's really all about the patients and people who need the care. It's not about the Media Lab. It's not about Intel or even the Mayo Clinic. It's about those people. Well, the Media Lab is kind of that kind of place in a sense from a research perspective, and I'll talk to you about that a bit as we go along. So, first of all, let me just begin by really repeating a message that I think has been said here a number of times, but I'm just going to express it in a very similar way. Ordinary people empowered by technology have transformed just about every segment of society. I mean, we know what we can do with technology. We've seen it. When you unleash the power of people in the sense that Craig talked about before, it's just amazing what they can do. But you've got to imagine that, and you've got to allow that to happen. And sooner or later, for all the talk about healthcare reform and about insurance and about measuring outcomes, that's got to happen. I don't think we're going to solve any of these huge problems that we have unless we ultimately find a way of unleashing the power of people. Let me kind of give you an analogy that makes me, that I think about when I think about where healthcare is today and where the mainstream is going when you look at the reform programs that are underway, the stimulus package, the things that are being thought about in Washington. It reminds me of an experiment or an event I read about that happened in 1959 when the Postmaster General of the United States said that the future of communication lay in the post office. In fact, the post office was going to improve communication by improving the delivery of letters to make them fast and speedy. And so in an experiment performed in June 8, 1959, they loaded 2,000 letters, first day of issue you see in the upper left-hand corner, into a nose cone of a Regulus air-to-ground missile, or ground-to-air missile, I think, replaced the nuclear warhead and put 2,000 of these letters in there, fired it off, and it landed 1,000 miles away, and they recovered it, and they sent the first, these letters to their destination with a letter from President Eisenhower saying, "This is the future of communications." Well, that was the same year when the first microprocessor or microchip was actually developed and the internet was beginning to emerge. And so I think we're looking at a situation today where we really are trying to fire a Regulus missile. And as Craig mentioned, hey, if we were to manage to make all records electronic and connected up, does that really make a difference in the system itself? We need to look, as we often do, for a paradigm shift. And that paradigm shift, at least as far as we're concerned, is empowering ordinary people in ways not managed before. It's always great to give a 2D chart. It looks like you're from business school if you do that. This is kind of my thought about how it's working. If you look at the cost as a percentage of GDP of healthcare, if we just do nothing today, well, it's increasing exponentially in a curve that goes up like that. And it's going to hit 20 or 25 or 30% of GDP very soon. We all know these figures. In my view, if you look at the reformed healthcare system, even the best that might come out of Washington, even the best that might come out of the stimulus plan, is going to straighten out that line they call bend the curve. Bend the curve is going to get us the same place, but 5 or 10 years later. The only way we're really going to attack this problem is by finding new paradigms and imagining new ways of empowering people. What we have to do is literally reverse that curve. And that brings me to why we're here today, why we're here, why the Media Lab is here. I really appreciate the invitation from David, and I think the vision that he had to bring together such an unusual place with this crowd here at the Mayo Clinic. In fact, in many ways, I think the Mayo Clinic and the Media Lab have something in common. They're a destination from people throughout the world to see the best practices in their own areas. But the Media Lab has always been about people. It's about 150 graduate students at any given point in time, master's and Ph.D. students, who are set loose completely free to invent and imagine, and in doing so, to demonstrate the possibilities. And so I think our role in this whole game of transforming healthcare, not just reforming it, is to demonstrate the possibilities of what ordinary people can do in control and in support of their own healthcare and of the system. Many accomplishments of the Media Lab are listed here. Any of you play a rock band or Guitar Hero or have that for your kids? Raise your hand, please. Okay, well, you will soon because they're coming out with the Beatles version in about a week or two. And that's when you'll be interested in it, as I will be. That was imagined at the Media Lab by Alex Rogopoulos about 15 years ago. He came out of our digital music group. And what that was all about was setting loose the creativity of those bright and energetic and really the students who don't know what they don't know on a particular problem. And that's, there's been many success stories in that way. Part of what I wanted to talk about today is not just health and healthcare and empowering people, but the process of creativity. I think that's one of the reasons and innovation that I was invited here today. And let me just talk a little bit about what happens at the Media Lab. It is a unique place where 150 graduate students are set loose by industrial sponsors, of which Intel happens to be one, to do whatever they want to. But they do it in an environment where we build what we think about. We just don't think about what to build. And that's one of my messages for you today. I think in the healthcare arena in this whole area, we've thought a lot about what to build, but how many of these things have actually been built and deployed? That's what we need to do. That's what we do at the Media Lab. If I could just run this, this video. What you see here is one of the many projects at the Media Lab. It's actually a robot that sits on your kitchen counter to enable the robot to be your weight loss coach. And it was assembled by a graduate student named Corey Kidd, where he had this idea of how a sociable robot sitting on your counter could actually enable you to stick with your diet better than a laptop or any simple other kind of artificial coach. And he built these in the lab. And most of the equipment here, other than the Intel chips that were inside, were actually built in the bowels of the Media Lab. Our students learned to build these things. And then they were programmed and deployed in the homes of about 30 people around Boston. And that's what I mean by building what you think about and then testing it and trying it. We learned a lot. Some of it worked, some of it didn't work. But when we took those 30 robots out of the homes, by the end of about 3 months, about half of them were wearing Red Sox caps. And one woman actually literally didn't allow us to take the robot out of her homes because she's formed a key relationship with it. And these days, they're so funny, but they're important. We learn a lot from those kinds of things. And these are the kinds of things I think that we all have to engage in by imagining what's possible. The Media Lab is what we call interdisciplinary. We have artists, and we have designers, and engineers, and computer scientists, and biologists. We have mechanical engineers and electrical engineers, all working in an environment where you build these things. The work is informed and paid for by sponsors. Intel is one of our benefactors, but it's all driven by the curiosity and the imagination of students. And incidentally, there are no secrets. All the intellectual property that's developed in the Media Lab is the ownership of everyone else in the Media Lab, and in fact, is published widely and it's available to the rest of the world. So this is an innovation environment that has been applied over the years, 25 years of the Media Lab, to what might be thought of as lifestyle kind of enhancements, games, I mentioned Rock Band, Guitar Hero, an alarm clock that rolls off your desk and runs around the floor after it goes off, if you've seen about that. And now at the Media Lab, we're applying it to this very serious and important problem. What do I see coming? This is a longer talk, but I think we're emerging from one stage of technology to another. Over the past 25 years, with Moore's Law and Metcalfe's Law, which governs the rate at which networks are useful, I think we've changed our basic lifestyle. And that's great. We all use computers to shop and to search and to socialize, and it's changed our lives in many ways, but I don't think it's really given us capability and control over our lives. And when I talk to crowds like this all the time, I say, do you feel more in control of your life using technology than you did 5 or 10 or 15 years ago? Well, even before the current economic crisis, the answer was almost always no, we don't. You can imagine what we've gotten now. And so I think the next stage of technology, of which this work we're talking about here today is part, is giving each human being the agency or personal control over their own health, wealth, and happiness. And those three things really come together. It is the vision of the Media Lab, it is what drives our students, it is what drives our faculty, and I think it's what's going to drive society over the years ahead. Let me get a little bit more concrete now, leading up to John's demonstration. About 2 years ago, I've been at the Media Lab for about 4 years. I actually come from industry, and I joined the Media Lab 4 years ago because it was about 25 minutes from my home. And what better opportunity, 25 minutes to your home, than to work with 150 or 200 of the world's smartest and most creative people. But I also had a particular interest in the healthcare world before I arrived. I actually co-founded a drug discovery company, cancer drug discovery company, in 2001. And during that period of time, I realized something about health and healthcare, and that was the asymmetry between patients, ordinary people, and physicians or clinicians was still there in the way it had been for many, many years. And we formed this group called New Media Medicine. We have 3 students. And the whole idea behind this group is to imagine a future, in fact, where you know, the asymmetry between ordinary people and the high priest of the medical community, the doctors, the physicians, the clinicians, the researchers, the administrators, go away. And that doesn't mean that every person takes total control of their health. That's an unrealistic view. Not one that we might not take at the Media Lab, but have it in the past. But that we have radical new collaborations that are defined, using technology, using the kinds of things that exist now or might exist in the near future. New collaborations between patients and doctors, clinicians, researchers, and others that will put everything on a level playing field. And basically, what we're really doing is imagining beyond what we call Health 2.0, the use of the internet, how can we explore the limits of what ordinary people can do in control, in the service of biomedical research, finding cures for disease, public health, spotting infectious diseases early, primary care, taking care of their everyday needs and that of their family, and ultimately, as has been pointed out, in prevention and wellness. At the Media Lab, we're trying to really break all the boundaries and ask what are the limits. And what I'm going to do is just give some examples of what goes on there, and then I'm going to turn it over to John. We have 3 students in the group currently. It's a tiny group. It's actually mine. This is what keeps me active and busy when I'm not dealing with the administrative burdens and the task of dealing with faculty at the Media Lab. And this is where the fun goes. My student Ian Eslick, who actually co-founded and sold a high-tech company, took an interest, as I had, in how software and software technology could be applied to healthcare. And he asked, how could patients with rare diseases, this is the question he asked, actually participate not only in advocacy groups and sharing ideas with one another, but actually be an important factor in using their own knowledge and data in finding cures for their disease. And this came to me, this project came to me through a fellow named George Dimitri, who's a clinician and a famous cancer researcher at the Dana-Farber Institute, who happened to be the PI, or the principal investigator, on one of the drugs of the drug company that I co-founded. And he came to me and said, you've got to meet this person, Amy Farber, because her ideas and what you're doing at the Media Lab are very, very much in tune, and maybe you can help her. Amy has a disease called LAM. I'm going to run the video here, and she'll describe it to you, and we'll talk a little bit about what this led to.
Lymphangiomyomatosis.
Which is LAM.
It's not really an acronym. The short version is LAM.
Your body is basically forming tumors.
Cyst growth.
Predominantly throughout your lung area, but it can be throughout your whole body.
It can be. The fatal part is the lungs. You need them.
Have they made any strides at all?
It's commonly misdiagnosed as
emphysema, other lung disorders.
Other lung disorders in non-smoking women in their childbearing years. On average, people go 4 years without a correct diagnosis.
All this clinical discussion doesn't answer
what we can do about it.
Not that so much, no. How have you been dealing with this? And that's really the question.
So we've started an organization called the LAM Treatment Alliance. And following that, we started to raise public awareness and raise money to fund research.
I want to live. I'm not ready to die. I've got a lot of life left in me, and I'll do anything in my power to help find a treatment in the fastest time possible.
So Amy Farber came to the Media Lab along with George Dimitri and said, I don't think we have the time. She doesn't have the benefit of time. This disease is usually fatal within 5 to 6 or 7 years. And although she'd formed a tremendous advocacy group and social network to support one another. Her vision and the vision of George Dimitri was that ordinary people, these patients with the Lamb disease, could become scientists. And what could we do to enable them to supplement the scientific and biomedical research endeavor around this to greatly accelerate it? In other words, how could they become scientists? And we've begun to explore this question by really pushing the limit on what these patients can do and actually starting to convince clinicians that data and hypotheses generated by patients, given the right tools, and using the kinds of technology that Craig Barrett talked about, nothing that advanced, really beyond the technology, could actually make a difference here. And so we've created, together with the Lamb Treatment Alliance and others, a website, a social network site, if you will, called Lamb Site. But this is not just an advocacy platform or a place for patients to get together, but where they're collecting the information about their everyday life, the experiments of their everyday life, and we're now providing them with tools to actually generate hypotheses using the data. And our question was, could ordinary people, could patients, without medical backgrounds, actually begin to understand the process by which they could evaluate this data and form hypotheses? Would they actually put their data into this website, and would clinicians actually begin to take them seriously? And I'm happy to report that although our work is very, very early, the answer to all those questions is yes. Gives us great optimism. Lamb's site has been deployed to about several hundred patients throughout the world today. They're actually conducting what I think of as an experiment or a clinical trial on the effects of estrogen on their disease. It was noted by a lot of these women, and we use natural language processing, it's a women's disease, as you know, to evaluate some of the chat in their social network, that the symptoms of this disease were exaggerated during their period, during their menstrual period. And so they themselves formed a hypothesis that the disease and the growth of the disease may be estrogen related, and they're now conducting a test to see whether or not that's true. But the really neat thing is they've entered a huge amount of their data. We've dealt with security and privacy. They're working together, and a handful of clinicians who are really ignoring this information and data are now working together with them to complete this test and move to the next one. And so there's an example of where you just simply up the expectations of what ordinary people can do. And if anything, that's my message to you. I think Craig's message, was really the first part of that, which is the technology is there. The second part of that is we need to up the expectations of what ordinary people can do in support of this whole process. And if we up the expectations, I think we're going to get tremendous results. I'll just talk about one more thing before I turn it over to John. Second student, Clark Freifeld, is asking the question, can ordinary people and can ordinary information taken off the internet actually be used to predict the spread of viruses and infectious diseases? And he, together with our partners at Children's Hospital, created a website called Health Map. Some of you may have used it. It's today used by the CDC. And what it does is it parses through huge amounts of information, both formal from the media and also informal sources of information. And it comes up with a map. And here's an example, if I can, let me go back here. If you can just run this right now, using some 30,000 news feeds and information from, if we can run this video, and information from, if you're back there, if you can run this video, good, okay. Information from social networks and other sources of informal information did a great job of predicting the early stages of outbreak of H1N1. We got excited about that and developed, and if you can run this real quickly, a handheld iPhone application that ordinary people can now use to make reports.
In one's neighborhood or around the globe, illnesses like the H1N1 virus.
Another new aspect that we're introducing with this application is the ability for any user to submit a report into the system. If you observe some sort of event happening in your area, like a school closing, that you would be able to take down some information about what's happening, and you can take a picture.
And new Outbreaks Near Me application saw 10,000 internet visits in just a few days after its launch. It distributes health alerts in 7 languages, and iPhone users can download the application for free at iTunes App Store. In Boston, Latoya Edwards, NEC.
So this was released about 2 weeks ago now. There are now 100,000 downloads, and we haven't had all that much publicity, and about 15,000 outbreak reports have been made. So I think we'll have more to tell you about this, but we were really experimenting with whether or not ordinary people using their iPhone would take an interest in making these reports, and the returns have been unbelievable. So what I'd like to do now is, if I could call up John, or you're back there, John Moore. Real briefly, John is a student of mine, and he just received his master's degree from the Media Lab. And he's a doc who I think is going to tell you his story right now. John?
Great. Thank you again for having us here, for having Frank and I. My name is John Moore, as he mentioned, and I'm the 3rd student in the group, and I focus primarily on the interface between patients and their doctors and trying to use technology to enable radical new paradigms in the way they communicate. So while Clark focuses on communities and global issues, and Ian focuses on disease communities, I focus predominantly on the interface between physicians and patients and other providers and patients. My background is as a biomedical engineer and also as a physician. And so the typical question that's asked of me is, what were you thinking, John? And that's the one that my mother asks continually, but hopefully she's starting to figure that out. And my reason is much like what Craig said, is we have the technology now. I felt like as a biomedical engineer, I couldn't have that big of an impact because the tools are out there. We can make the measurements. We can send the information. And as a physician, I felt ineffective, however, because I felt that the technologies were not quite to the point where patients were really pulling them. We were pushing the technology out to patients. And yes, we are seeing some benefit, but we aren't to the point yet where patients are really grabbing a hold of it and saying, that's what I want. I want to be actively involved, and I want to change my health. And that's why I really feel that this statement that media is the medicine is really the future of medicine in the next couple of years. And that's why I joined on at the Media Lab. I believe that we're putting patients into this paradoxical situation where we still have that priesthood of physicians who make the decisions. They determine the guidance for the patient, but then the system treats patients as if they're incapable of really reasoning with this data or making meaningful contributions, but then expects them to follow their blood sugars, to report a lot of information, to take their blood pressure every day. And so what happens here is the patient gets this thin stream of information, but then is required to report an even thinner stream of information back to the healthcare system because of the constraints that are being placed. And as a result, patients are moving towards the internet. And the problem is not that the internet is not a great resource, but that the bandwidth of this channel really outweighs those other channels that are involved between patients and physicians. And what I really believe is that technology that exists already, but thinking about new types of human-computer interfaces can really change this whole paradigm. Unfortunately, as a physician using the technology today, I felt that I was more taking care of the computer while my patients were suffering. So what I really want to do is, today my goal is to show you some technologies that I built over the past 2 years. And my goal is not to tell you that I have the answers into whether they work or not, but to recruit you and to recruit your colleagues. So the goal of my technologies is to be open source and to get them out there to everyone who wants to try innovative new paradigms in care and let them experiment and help me answer some of these questions. So I'm going to show you some videos and kind of talk over top of them. So here in this video, what you'll see in the background is a system that I'm designing to reinvent how doctors and patients interact in the office. I firmly believe that if we want patients to be active participants, to be out there using devices in their home, taking their blood pressures, that we need them to be active participants in the office as well. And the tablet PC, the PDA, those tools are not going to allow that. What we need is patients to be able to see the information. Well, my questions are, what if we can allow patients to actually be the ones driving these devices? Let's take it to an extreme. Maybe I, as the doctor, am not the one telling them what they need to see, but they're coming in and telling me, this is what I need to figure out, doc. This is what I need to do to make my life healthier. And this speaks to the issues that Victor Montori was talking about fit. Who knows fit better than the patient, right? So let them control it. Now, what does this agency do? This agency and this ownership of decision-making, how does it transform patients from feeling as if they're being demanded to produce some result to asking for help? And how does this change adherence? How does this change their follow-up in coming back for office visits? How does it change their willingness to go for that colonoscopy? If we're changing the paradigm so that they're involved in the decision-making process, they're helping to weigh the decisions, and they're driving the boat here. Now, the next question that I want to ask is, what if those interfaces in the office are actually used to program the tools that patients are using out there in their life? So currently, a lot of the technologies that exist are divided from what happens in the office. What if instead patients don't have to go home and set up these devices, but that decision-making process that they've made in the office actually drives this device out in the real world? And how does that new channel of communication that is asynchronous and continuous change the way we care for patients? And the next part here is, well, how does this information then fit into the rest of the patient's life so that we can provide social support for them in an ongoing manner? And I firmly believe that the future of interfaces for medicine deals with asynchronicity. There's a lot of talk about video conferencing in medical care, but video conferencing offers the same time constraints, the same financial constraints as in the office care, except for remote locations. But what if we can push it further and do a lot of things asynchronously? So if we can provide little socially supported messages to patients saying, you did a great job taking your medications and it's really helping take care of your diabetes, rather than having to call them, have them answer the phone or call back to us. But what if we can do this in ways richer than SMS messages, but do little asynchronous video messages that are deeply ingrained in the context of the problem? Even further, how can patients communicate information back to the office in ways much richer and much more engaging than with email? So I'm doing a lot of work with artificial agents, intelligent agents that know the core questions that need to be asked and can structure the information so that physicians can then triage care more appropriately and decide whether video conferencing is appropriate or bringing the patient back into the office is more appropriate. And speaking to Craig's comment about that 5-page form that he has to fill out every time he comes to the Mayo Clinic, what if he can sit on his couch and have a conversation with an artificially intelligent agent that will give him plenty of time to enter that information? And how will this type of situation affect people that have stigmatized diseases? Will they be more likely to talk about eating disorders? Or will they be more likely to talk about sexual abuse or alcohol abuse or drug abuse? There are a lot of questions to be answered here. And the other part of the work that I'm doing here is, how can these artificial agents become social actors? They're not just some entity that you interact with in your home, but when you show up in the office, that agent is there to advocate for you. Here there was an image there showing that the patient showing their foot and getting an image taken, but what if these agents can also help you take your blood pressure and follow your blood glucose, but allow you to do that in a way that allows you to help interpret the results yourself so that you're more motivated intrinsically rather than by these outside forces? And what if when you show up in the office, and maybe if you're timid at first, you can see that, that Linda here, my agent, is up on the screen already and caring for a patient. What if that agent can brag for you and say, well, Mr. Jones has been doing an awesome job. He's down in the green, so that eventually the patient can learn to brag for themselves and feel and really feel proud of their results. So this is the type of engagement we want to get. And so I've asked a lot of questions. And in order to hopefully compel you that this is some interesting work and recruit some people to help us in answering some of these questions, what I did was I took a very specific case and applied these technologies to a problem, and that problem was HIV medication adherence. So HIV, I think, is a very interesting area to discuss because not only is the adherence extremely poor, 33 to 88%, depending on what you look at, but the majority of adherence is less than 50%. But we have great treatment. And so you say, you tell a patient you have a disease that will kill you, but we have a treatment that will save your life and let you live a full life. Why do fewer than 50% of people take these medications? And I firmly believe it's not the doctor's fault, it's not the patient's fault, it's the fault of the process. So what I'm going to do now is show you some videos that show you the tools that I used in a pilot that I did with 4 patients in the Boston area to start looking at some of these questions. The first thing I did was I created a collaborative interface here where patients could help schedule their own medications. So give them some agency, give them some ownership of the decisions that are being made. So they just put their finger on the screen and they drag it and say, "Doc, you know, I don't get up at 6 in the morning," or "I get a stomach ache if I take too many medications at a time." Really give some information about what's going to fit in their life in this collaborative interface. And it creates this visualization of a clock that shows when their medications are due. When the patient then goes home, this information is available to them on their cellular phone. So this, I'm showing just an emulator of a phone up here. And also on that little device that you saw in the other video, it's called a Chumby. So they have a little home device, they have a mobile device, and I've even done some work directly on the television. So when someone's watching Oprah, it could then remind them to take their medication, and it could be scheduled based on programming or other things in their life. And the patient here can click on this clock at any time, and they can click on one of their adherence intervals, and they can see all of the medications that are due for them at that time and get instructions directly from their provider that are specific to that. So this is the basic stuff that we need. But where I really wanted to push the limits were in what the patients can do to be involved continuously with their caregivers. So they can report each of those medications, whether or not they took it each time. And then that is reflected in the interface, so they're checked off now. But then what they get to see is their performance over the period of the past week. And I really wanted to push things here. So what I did was I give them a graph of the estimate of their blood concentration of these medications. So traditionally in medicine, we feel like patients can't understand pharmacokinetics and that, you know, absorption and elimination are too complicated. But the marvel of modern information technology and modern interactive technology is you can make something so personalized and so dynamic that you can just watch this curve, and people learn in about 2 minutes that when that curve's falling, it's because I forgot to take my medication, and that means it's not working. So suddenly the issues of taking my medication twice at once because the doctor said 2 times a day, so I figured I'd just fit it in, they start to understand that, well, that'll make it shoot off the top, and I'm more likely to get side effects, which is a big issue with HIV medications. And pushing this even further, what I did is I used this quantitative information to drive a disease state simulation. And so what I mean by a disease state simulation in this case is a simulation of HIV for this patient at this moment in time, to the best of our knowledge. So let's get away from numbers and a patient saying, oh, I have a viral load of 15,423. What does that mean to me? But what does my disease mean to me now? Because they don't have symptoms. Why are they compelled to follow our recommendations? Let's let them see it, let them live it, and understand and come back with more desire for education. And so here, as I play this little movie, now the T cells here, the bigger gray cells, are surrounded by a protective medication barrier. And they look kind of happy. And the HIV virus, the other little dots around here, is suspended. It's sitting there waiting for a chance to attack. But because the patient is doing well, they don't have a chance. So we'll follow along in time here. The T cells are moving around, floating around healthy. And we'll follow in time a little bit. And what you'll see is the patient will miss one of their medications. The little X will come up. And that blood concentration for that medication falls into a region out of the goal area. So now what happens is if we look at that disease state simulation, now there's a break in the barrier. and that virus is actively attacking those cells. And so it's teaching patients about the idea of medications working collaboratively together, and that if they miss only one, it really does make a difference. And now what's happening is, now that level of medication is even lower, so all of their T cells are getting attacked. And now what you'll see is they'll start missing all of their medications. And then you'll see a state of the simulation where they're fully getting attacked by the virus. And the goal is to ask the question, does this type of simulation give patients a visceral response to their disease? They don't have symptoms, but could this interface be persuasive in proving to them that every medication that they miss really does make a difference? And might it even make them feel sick to their stomach because feeling that they've lost control? But what it also does is, because it's directly linked back to the physician's office, it allows the physician to push out messages of social support. So here's a little video that I sent to this patient saying, you're doing a really great job, keep up the good work. Or I could be saying, you know, I saw you just reported that you missed one of your medications, and that the reason was because of a side effect. Well, how about you try this, because it's very common for patients taking your medication to have that side effect. So it's an asynchronous way of practicing medicine that's still socially engaging, and that dramatically changes the way costs are distributed and time is distributed. So in talking about the results of this study, there were only 4 patients. It was a pilot. So the numbers don't mean a whole lot, but 2 patients started with optimal adherence. We chose 2 patients with good adherence to start. They maintained optimal adherence, and they still enjoyed using the interface. 2 patients had suboptimal adherence, down in the 80s and lower, and both received significant increases in their adherence. But what was really more important to me was that I was there for every visit that the patients came in, and they were coming in with questions like, I saw that spot where my line dropped down in there, and I saw that virus attacking me, and it let me know I was doing a bad job, and I took my medication immediately. And other patients would say, you know, I check that simulation every day, and I see the virus floating around there, but I'm not going to let it get to me. So it was changing their understanding of the disease, and it was changing their ability to reason with that information. It also, yeah, we'll get this video off of here. It looks funny on my face. But, so the other things that we experienced were that patients who previously thought they were doing very well with their adherence now realized that they weren't doing so well. And there was one patient who was completely unwilling to use a pill box in improving her adherence. But because of what was revealed for this, and because she saw that simulation attacking her regularly, she said, well, I'm willing to give it a try now. So I don't see these technologies as being the end-all and be-all solution, but I see them as a way to engage patients in a very different way in healthcare. And to change things so maybe patients will start pulling these technologies out of our research rather than us trying to push it out to them. I'd like to thank you all again for having us. And as I mentioned, really a big goal of this for me was to be an open invitation for collaboration. And the idea that all these tools that I'm creating will be open, and I will help people to integrate them into problems that they have. So if you're an expert in hypertension or diabetes, or you have colleagues who are experts in those areas, and they want to explore radically new paradigms in how we can use technology, please just shoot us an email anytime. Thank you very much.